Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit Podcast.
Hello, listeners, and welcome to another wonderful episode of the Med Edit Podcast.
Today, we talk allergies. Why talk allergies, you ask? Well, allergies are among the most common chronic conditions worldwide.
I don't know anybody that's not allergic to something, whether it's food or pollen, pets, something.
Absolutely. I'm so glad today we have Dr. Amanda Lewis, our favorite allergy/immunology specialist, to help tease out some of the facts from fiction.
Me too. And we will cover why we get allergies. We'll talk about drug allergies, food allergies, and of course the dreaded hay fever or allergic rhinitis, which you may hear I'm suffering from currently. So this is perfect timing.
After that, we will go into more detail about allergy testing in our Hollywood Hype section, where we discuss recent social media posts from Hollywood it girl Joey King. Again, we have Dr. Amanda Lewis on today's episode. She is a board-certified allergist and immunologist managing a busy practice here in Lubbock, Texas. Hello, Dr. Lewis, and welcome to the Med Edit Podcast.
Hi, good morning. Thank you for having me.
We are so happy to have you on the podcast today. Let's start with some basic information for everybody. Why do we get allergies in the first place?
Allergies or an allergic reaction really begins in the immune system. Our immune system's main job is to protect us from invading organisms that can cause illness. If you have an allergy, your immune system mistakes an otherwise harmless substance for an invader. And in the allergy field, we are going to refer to this substance as an allergen.
Okay, so Amanda, why does this allergen lead to a response by our body, though?
Good question. So basically the immune system is going to overreact to that allergen by producing our immunoglobulin E, which is our IgE, antibody. It's our allergic antibody. So antibodies are proteins that circulate in the blood. And they have different types with different functions. And so here are IgE. They'll travel to different allergic cells like our mast cells and our basophils, and it will activate them to release signaling chemicals like histamine and leukotrienes and prostaglandins. And then these chemicals help give us our allergy symptoms that range from just being congested to life-threatening anaphylactic reactions.
Right. What kind of symptoms can occur with a said allergic reaction?
It can vary based on the allergen and then the system that is being involved. So, for example, in the nose, we can have sneezing, we can have itching and a runny nose and postnasal drip. But for a food allergy, we can have hives, vomiting, cough, shortness of breath, even uterine cramps.
Oh, even uterine cramps from an allergy. That's interesting.
Great. Just what we needed. More excuses to get uterine cramps,
right?
I know, right?
Allergens.
What are some common allergens that we see?
So pollen from our wind pollinated plants, also animal dander, mold, dust mite, foods, medications, and also latex.
We have a lot of those allergens here where we live in West Texas, don't we, Cari?
Yes, absolutely. And it's really interesting you mentioned latex. This is kind of an aside, but I saw something online where some people were having to sell their tickets to like the Taylor Swift concert because there's like some balloons, latex balloons that are part of the show or something like that.
Oh, no way.
And they have like severe latex allergy. So I just thought that was interesting. I just saw that this morning. So yeah, I went to see Taylor Swift. I don't remember latex balloons, but apparently they're there and it's a problem if you have a latex allergy. So
they better disclose that, I guess, when
right?
you buy your ticket.
Yeah,
that's important.
Yeah, exactly. All right. So we're going to talk about some of these in more detail. Let's talk drug hypersensitivity.
Okay, so there's two kind of big overarching categories of adverse drug reactions. So type A reactions are more common and they're somewhat predictable. So for an instance, if you take an antibiotic for a sinus infection, you can have diarrhea. That's kind of one of those things that unfortunately we'll see. Or if you take too much acetaminophen, it can damage your liver. Type B reactions are not as common. They're up to about 15% of our adverse drug reactions, and those include our immunologic drug reactions. So that would be an anaphylactic reaction to an antibiotic or another reaction called a Stevens-Johnson syndrome, which is basically where we get pilling of our skin and even our mucous membranes with that. And that can happen to common medicines, even like allopurinol. Actually, there's 4 categories of the immunologic drug reactions, but I'm not going to put you all through all that information.
Yeah. I remember seeing Steven Johnson's as a resident.
Mm,
So scary.
it is really
I mean,
scary.
like those patients go to the burn unit just because of the amount of like water loss and everything. And it was crazy. I was freaking out.
It'll make you not want to take any drugs
Yeah,
ever because you'll be
exactly.
so scared of this happening.
Right.
But, in my practice, prescribing medications all the time, especially antibiotics or any medication, and a patient will say, oh, I can't take that medicine. I'm allergic to it. So we always ask, what is your allergy? Can you explain it? Can you give me some more detail? And a lot of them will say, well, it upsets my stomach. And so you're like, well, that's not that's maybe more of an intolerance than an actual allergy. So a lot of times what I'll do when patients come in, they have a very long allergy list up on their top of their chart, and we'll say, let's just go through each one of these and find out which one's a true allergy versus an intolerance. But is the main treatment going to be for those people who have intolerance just avoiding the medication? Or for those that are actually allergic to it, what are you going to do if you know that you do have an allergy?
Right. So for an intolerance, it is hard to get around some of those symptoms like the diarrhea with the antibiotics. We can try probiotics, potentially taking the antibiotic, depending on which one, with a meal to try to reduce some of those side effects. For people who are allergic in the sense of they have hives, vomiting, problems breathing, that type of thing, we can actually trick the immune system into not reacting to that medication. That's typically done in the ICU setting. It's called a desensitization because these are life-threatening reactions, right? Another interesting fact is that actually a lot of people will outgrow the drug allergies, especially within 10 years. And penicillin is a very common one that we test too for that. And we actually have great skin testing for that. And now the research is even really suggesting that we can, depending on the history, really just do a graded drug challenge in the clinic.
I have a sweet friend who her daughter last week was diagnosed with a penicillin allergy, truly an anaphylactic one after having a pretty severe rash, hives reaction with it. And so they went in and got allergy tested. But that's what we were talking about because she was like, oh, yeah, I got to get a medical alert bracelet for her and kind of go through all those worrisome things. But hopefully, like you're saying, within 10 years, hopefully she could grow out of that. It won't be as much of a scary thing. Sending your child somewhere worried that they have an anaphylactic potential reaction. But one of the things she had said, which I thought was very notable, was that she said, I'm thankful it's a drug allergy and not a food allergy because food allergens are much harder to control. They're in the environment. Your kid goes to school, a friend hands them some kind of food. You're on an airplane. They talk about like peanuts on the airplane, all those types of things. But what about food allergies? Tell us a little bit more about that.
So food allergies, you're correct. They're very, very difficult to avoid. And even in certain food allergy situations, we can actually have reactions to airborne exposure to it. So an example is like, cooking seafood. It will aerosolize the allergen and people can have allergic reactions that way. So for the food allergy, our immune system is the same thing. It takes, let's say, that peanut protein and it goes, I don't like that. That's a threat to me. I have that allergic antibody to it. It causes that immune system activation. And then we have symptoms ranging from hives to vomiting to repetitive dry cough to even, passing out. So it's usually a reaction to a protein in a food, but we do have also the potential for an allergy to a carbohydrate. That's usually in the setting of a tick bite. There are 9 major food allergy groups. Now, there used to be 8. Now, we finally added sesame seed in. So our top 9 groups are cow's milk, egg, peanuts, tree nut, soy, wheat, finfish, shellfish, and then the sesame seed.
Oh, wow. That's a lot.
Yeah, and I actually do see a lot of people have food allergies that aren't in that top 9 group. I've got kiwi allergy and corn allergy, so those are the most common, but that's certainly not everything we could have an allergy to when it comes to food. And then just like with the medications, we can't have intolerances to food without it being a true life-threatening food allergy. I mean, it is really important to understand the difference because with a true food allergy, it's not one of those, okay, if I eat it, my stomach's going to hurt, but I can still eat it and it's going to be fine. In the situation of a true food allergy, you need to strictly avoid. We need to read food labels. It's quite an undertaking to do.
Yeah. I remember being a kid, and I don't know what the facts or testing was around this. My mom tells me to this day that I had a milk allergy. as a young kid. And I remember like having this brown bottle that we had to do drops in my mouth before I did milk products. I don't know. I was a kid, so I don't entirely remember it. Thankfully, I do milk products just fine now, but it's just very interesting because I remember having to do it and be like, oh, this is so horrible. And now I'm like, did I really have a milk allergy? Was that a real thing? I don't know.
Well, I do think that that brings up a good point because I personally know some people too where they've said, "Oh, my kid has this kind of food allergy," and then they list out about 20 different foods, right? And then they're cutting out gluten, they're cutting out grain, all the grains, they're cutting out milk and dairy products, they're cutting out, fish. And so this poor child now eats basically nothing, such a restrictive diet when they probably didn't have a true food allergy to begin with. So tell us, like, what are some actual symptoms of a food allergy?
Yeah. So, hives, flushing, itching, the skin symptoms are really very common symptoms of the food allergy. I can also see swelling around the eyes, sneezing, hoarseness, shortness of breath, wheezing, a repetitive dry cough, vomiting, diarrhea, really bad abdominal cramps to the point where they don't really want to move a lot, and even passing out, which is usually from the low blood pressure. It usually occurs within 2 hours of eating the culprit food.
So all of these allergies, all of these reactions would happen within 2 hours of eating the food, right?
Typically, the exception would be with that carbohydrate allergy. That can be a delayed one there.
Okay, that's good to know.
Mm.
It's also, I don't see just nausea or my tummy doesn't like it because I feel like that is one we see with a lot of kids. And then the parents are saying, well, it just doesn't sit well with their stomach. They have an allergy to it. So it doesn't sound like that quite fits that picture.
Yeah, and I try to, customize it for the family. And so it's like, if they don't do well with it and we don't have to avoid all these other foods, well, then, don't feed them the food. I don't think you have to go through the expense of an EpiPen and doing all those things. But then, a lot of times our body can help fix things, especially when we're children. And so it's one of those, okay, well, cut it out for 6 months to a year, and then let's try to reintroduce it and then see how we do. Because even with the life-threatening food allergies, we can outgrow some of them. Milk is one that we normally outgrow, as well as egg, but unfortunately peanut, tree nut, those in the shellfish and the fish, they don't usually go away.
That's good to know that there's a difference between which allergen one and how likely you are to outgrow it.
Yeah.
Can you explain cross reactivity? Because I think that's a really interesting topic to talk about and people will look at that more.
So cross-reactivity occurs when proteins that are found in different substances are so similar that our immune system gets confused and will have allergy-like symptoms with them. So an example is if you are allergic to ragweed pollen, you can have an itchy mouth when you eat raw bananas.
Ooh,
Crazy. That's so cool.
that is really cool.
I mean, not cool if you have itchy mouth from bananas,
No.
but it's pretty cool in general that our body does that. That's crazy.
So a lot of times, actually, if you heat up the food, then we won't have those symptoms. It's a diagnosis called pollen food allergy syndrome. And it is possible to actually have an anaphylactic reaction. It's very, very rare, but it is possible to have an anaphylactic reaction in this situation too.
That is very interesting.
Yeah. And, kind of some of the questions we all get about these food allergies is, do the food allergies get more severe every time they occur?
No. So unfortunately, our prior reactions don't predict our future reactions. And so it's not going to get more severe, but it's also, we can't say, oh, last time all I had was a little bit of itching and a little bit of hives, but I didn't have to use Epi. I was fine. It wasn't full body hives. That doesn't mean that the next time we have that exposure, that we're not going to have the vomiting and the low blood pressure and the passing out.
Okay. So what about avoiding common food allergens in babies? So I have a 4.5 month, he'll be 5 months next week. And so we've actually started talking about introducing like that the peanut allergens to him. And with my older son, we did it with the little bombas, puff peanut butter puff little things.
Those things are so good.
I have not actually tried one personally.
God. I like them.
But we don't.
like them.
I know that's this kind of stuff has changed, and they talked about introducing these allergens earlier and younger. Give us your perspective on that.
So usually you want to introduce around 4 to 6 months of age. At one point our guidelines said wait until 3 years, and then we are speculating if maybe that actually caused some of our increase in food allergies that we're seeing. Now, the exception is if the baby has moderate to severe eczema, then they really need to see an allergist to have skin testing, or the other possibility would be get blood testing for peanut before they introduce, just because they tend to have a higher incidence of a peanut allergy. So for both of my boys, I definitely introduced peanut early. I did peanut butter, and it's a choking hazard in young kids, right? So you have to thin it out with water into a puree. So I did that. Or if people are doing baby-led weaning, they can spread peanut butter on toast.
Yeah, we did baby-led weaning for my oldest too. He peanut butter all the way. And I think one of the things that at least I had read with that was that this is actually really beneficial for people who have a family history of peanut allergies. Is that correct? That it might also be something to maybe even more emphasize if there is a family. I don't have one in our family, but it was something still that I thought was important to do.
So there is the thought that, yes, keeping a certain amount of peanut protein in the diet consistently could help prevent the peanut allergy. It's not 100%. I've definitely had families where this has happened, but I also have a lot of families where, one sibling has the peanut allergy and then we're terrified to introduce it for the younger sibling. So in that situation, we kind of talk through, do we want to introduce it in the office, things, to help them feel comfortable. I think I probably wasn't very nervous about, just because this is like what I do. I do food challenges routinely, but for people who don't have that experience, it's like, oh my gosh, we couldn't have peanut, and now it's like, what if they have an allergic reaction? And it's scary.
I guess that could also brings me up to a question too. When you are doing something, let's say like baby-led weaning, where we are introducing new foods, they always recommend a new food once a day, like not introducing multiple different new foods on a certain day. What are your thoughts about that?
I would agree with that, especially when it comes to the allergenic foods. A lot of times we're not going to have a reaction, the very first time we eat something. Of course, there are some people that will, but normally I've had peanut once or twice, and now this third time I've had it is when I've had the reaction. Of course, there are always kiddos that they've had a little bit of exposure to the peanut in other ways before, and then they're going to have a reaction the first time. And so usually I like to do one allergenic food at a time when we're first introducing, because then if we have a problem, we have to go, okay, what foods did you eat? So unfortunately, some of those ready-made, things to help prevent food allergies, it's like, if you have a problem, you've had all the major food allergens, and how do I know which one? And then we're testing to all of them, and it's a difficult situation. So when we're introducing, I prefer to do one thing at a time.
But we can all admit that doing that with any child after the first one is really hard, because I don't know about you guys. I know we all have two, and we all have two boys, and my oldest would hand random stuff to my youngest all the time. So it's like, I don't know what he's exposed to.
That is hard when you're trying to balance it with all the kids, for sure.
So did you have bananas today?
Oh, see, I was like a very, like, it's a choking hazard. It's a safety hazard. So I kind of like train my toddler into like not handing things over.
See, I've got that Solid Starts app, the baby-led weaning thing. And I am such a stickler, like to this day with the choking stuff. My 3-year-old still has never had a hot dog. And like grapes, I've like cut those things up so tiny. So I think that there's definitely different ways to approach it. And especially with the allergens, I do think that is the benefit of baby-led weaning and not doing all the purees as much, so that you can really figure out what you're giving them each time. But also tell me a little bit more about food avoidance for these allergens. Do you have to do this the rest of their lives? Again, is it something they're going to grow out of? Is there some way to adjust this?
So a lot of children will outgrow milk and egg allergy, for instance. Some of them, like the peanut and the tree nut, tend to be more of lifelong. But that being said, there's still about 15 to 20% that could actually outgrow in that situation. So how we've approached this for many years has just been, we have to unfortunately avoid the food. Recently, a medication named Xolair got approved for prevention of food allergic reactions, but it doesn't mean that we can still free eat the food. That's for children 1 and up, and as well as adults. Of course, there's risks with everything we do, right? So it's one of those, if we have a food allergy, we need to talk with our allergist and see if that's the right approach. There's also oral immunotherapy that is being used. Only one of them right now is approved through the FDA. It's for peanut. It's called Palforzia. But we do have a lot of allergists doing the oral immunotherapy, which is basically where we eat small and increasing amounts of our food allergen until we get to a stable level. that would then protect us against an accidental exposure, and also in certain circumstances, depending on the level, allow us to free eat. I have found that most kids who have done that, then they don't really have a big desire to eat the food because they're having to eat it. Imagine having to eat the same thing every single day. So
yeah, no, not fun. I guess maybe when you're a toddler, they might like it if it's one of their comfort foods.
I mean, if it's French fries, my son will do it
Right.
every single day. Or nuggets.
Mine would be like candy. That would be what mine.
Yeah, exactly right. Yeah, it depends on the food.
We do the Reese's because I'm like, it's got the peanut butter, so it makes it feel a
That's
little
a
bit
good
better.
one, right?
Yeah.
Sneak in your peanut butter that way.
Potty training rewards. So
yes.
All right. Lastly, we're going to talk about the dreaded hay fever or allergic rhinitis, which I mentioned is perfect timing for me. I hate when I have it. It's the worst. I hate coughing, all of it. Now, I know this occurs because, again, like we talked about, your immune system mistakenly identifies something harmless as the intruder and leads to all those symptoms we hate, right? In our nose, our throat, our eyes, our ears, our skin. I know this is a silly question, but Dr. Lewis, how commonly do you see this in your practice?
all the time. Allergic rhinitis is very common where we live in West Texas. So seasonal allergic rhinitis is due to a pollen, typically from wind-pollinated plants. So those of you familiar with West Texas and all of our wind, now you understand why. I see it all the time. It can also be from pet dander, from mold. And there's a misconception. I think a lot of people think we only have mold if it's water damage or in the soil, but we actually have molds that like the dry, windy days. And then there's also dust mites or even cockroach particles. And so the pet dander, the mold, the dust mites, and I should clarify indoor molds, and the cockroach particles, those cause the perennial, meaning year-round allergic rhinitis, which is basically all the nasal issues that we get, while the pollen is more of seasonal. But again, in West Texas, it's almost kind of becoming more perennial. We don't get too cold in the winter, so.
Makes sense.
And then, of course, not all nasal symptoms are actually from an allergy. About 1 in 3 people may actually have nasal issues from things that aren't allergies. So one of the things that we can see is that we can have some sensitive nerves that are in our nose. And so irritants like smoke, strong odors, weather pressure changes, all those things can trigger very similar symptoms to the allergic nose. It's just a different process by how it happens.
Ooh, weather pressure symptoms. I have a lot of patients that come in and talk to me about that, saying that, oh, I feel, they point out the window in my office and say it's the weather pressure change. So that's really interesting too. Okay, so what everyone really wants to know, bottom line, is how do we make it better? What's the treatment?
Yeah. So specifically for the allergic nasal condition or even allergic eye condition, we have 2 broad categories, medications and then allergen immunotherapy. Of the medications, the nasal steroid sprays are usually the most effective, and they're typically first line with, of course, exceptions in certain circumstances. Other options are the oral antihistamines. We actually have nasal antihistamine sprays. We also have cromolyn nasal spray, and then leukotriene receptor antagonist, which I know is a mouthful, but that's basically the montelukast type category. The second generation oral antihistamines are usually preferred to the first because they don't cross the blood-brain barrier as much. And so they're also not going to cause as much of like the sedation and the dry mouth. And then something to just kind of be aware of with the leukotriene receptor antagonist, unfortunately, is that they do have a black box warning from the FDA for the potential to cause mood issues there.
Yeah, so that's going to be like your montelukast, like you were saying. That's been an interesting thing where they put that out, a couple of years ago with that black box warning. And so I've had so many people on it. And a lot of our teenagers, especially parents, got really scared and they started asking about the mood issues. You know, we're talking about depression, suicidality. And so what I've counseled my patients with, maybe hopefully this is correct, is that we kind of, see if they're at risk already, if they, is the medication helping, can they be off of it? Do they have underlying mood issues? Do they have symptoms, or do we just monitor that for these things?
Yeah, so if they have no symptoms of mood issues, then it's normally, hey, that this is a potential, let's just watch for it. And then if it happens, it may not be the medication, but let's stop it and just make sure that that's not it. If someone who already has underlying anxiety, depression, then it's okay, is this making it worse, or do we think this is causing it? And if so, let's stop it. We have so many other options. There's no reason to be on a medication that's going to make you feel bad. And then in young kids, I do tend to see nightmares, and some kids get really irritable on it, and it's like, it's just not worth it. Let's not do it.
That's good to know.
Yeah, we had to stop it on our son for that reason.
Yeah. Yeah. And then the other treatment option is allergen immunotherapy or allergy shots. It has an excellent benefit with 80% of people seeing an improvement in their symptoms. It is a long-term time investment. And I think that's really the hardest part. It's like 3 to 5 years with a small, very, very small potential for an allergic reaction. And think about it, you're getting a shot with things that you're allergic to. And that actually, the benefit with these allergy shots is really what drew me to the field of allergy and immunology, because I was in my training and, I did internal medicine before allergy. You either do internal medicine or pediatrics first. So I did internal medicine before, and I saw like, oh my gosh, these people do great. And I do love to see kids. I just, picked one residency, right? And then as benefit of my fellowship, I was equally trained in both. So now I do adults and kids for allergy and immunology. And it's just the improvement in the quality of life is just, there's nothing better than that to me. So,
I love that. And so you said one thing for reference to, you said that for these allergy immunotherapy injections that you would do 3 to 5 years, but it doesn't have to be lifelong.
No, of course, I feel like I'm saying this a lot. Of course, there's always the exception, right? And so I definitely do have people that we try to stop it after 5 years and they're like, no, I'm miserable. I want to go back on them. That type of situation. And we have to just be flexible with what works for them, right? And so the research says 3 to 5 years, but we can't put everybody in a box.
Right. And I want to stress this too, because again, being a primary care doctor, people come in to me all the time saying, hey, I just need an allergy injection. I'm like, I don't think you know what you're talking about. What they're thinking of is a shot of like steroid. They're like, oh, give me some Kenalog. I always need that. I feel so much better after you give me a shot of steroids. That's what the allergy injections are. But for very clear clarification here for our listeners, that is not what we're talking about. You do not need injections of steroids. We're talking about an actual true immunotherapy that works completely different.
Right. So the allergy shots are made up of the allergens that you would have tested positive to on skin, which is a little bit better for detecting, or blood work there. The quote unquote allergy shot where it's steroids, those are actually very bad for us. They increase our risk of cataracts, glaucoma, weak bones. And we actually have some research in the asthma field that 6 to 7 courses of systemic steroids, meaning like full body steroids like prednisone pills, a Medrol dose pack, or a steroid shot, increases our risk for those long-term side effects.
That is so good. I'm like, that needs to be written somewhere in all urgent cares and posted on the wall so that everyone can just know, hey, this is from our allergy expert. Please stop giving out all of these steroid injections.
Yeah, I found it, I think, like buried in the GINA guidelines. So it's just one of those.
So good.
Yeah, I tell people all that all the time because I'm like, I wouldn't be doing the steroid shots personally.
Oh, no, same here. I'd rather suffer through a little bit of some allergy reaction than have to just keep doing that over and over again, of course.
Mm-hmm. And then there is, another thing that we can sometimes add on to people who are suffering from allergies, and that's allergen avoidance. But it's just, if you're allergic to the pollen, I'm not going to say live in a bubble. Don't ever let your child go outside and play. Like that's not good for them. And so the research keeps going back and forth on whether dust mite changes help. And so we kind of let people decide how much they want to go into that because that's quite a big undertaking. And then pet avoidance does have some good research there. But I also understand a lot of people, their pets become their family.
Yeah.
Makes sense for sure. This has just been great information though. Absolutely. Everyone is always asking these same questions, even in my clinic, so frequently. So even for me, this is nice stuff that I can take back little tidbits.
Good.
Yeah, absolutely. All right, we're now going to transition to some frequently asked questions about allergy testing. I know we briefly mentioned it earlier, but allergy testing, very common in everyday practice and apparently in Hollywood, it seems. So recently, actress Joey King shared an image on Instagram of her own skin allergy results. She's also discussed reactions to certain foods in the past, indicating maybe a food allergy or sensitivity like we talked about earlier. And I'll just summarize it for you. So she posted a photo showing a typical puncture or scratch test, which typically tests for immediate allergic reactions to multiple substances. In her case, it looked like there was about 50 substances that were tested, and there were multiple bright red spots next to her markings. Dr. Lewis, we know you are not treating Joey King, even though that would be amazing, but let's break down some common myths. First, does an allergy test tell you how severe your allergy can be?
So the allergy skin test is a guide to determine the likelihood of an allergy being present, but not the severity. We can always have false positives or false negatives. In general, the larger the area of swelling, we call it a wheal, the more likely that allergy is going to be a true allergy.
What can someone expect undergoing skin allergy testing or the prick test?
So it's typically done in the office and it takes about 20 minutes. They're not painful. They use little needles that just barely prick and penetrate through the top layer of our skin surface. You usually don't bleed or feel more than a mild kind of brief discomfort there. The most common complaint I hear is like, I'm so itchy after doing the skin test, and it doesn't help that people then stop the antihistamines before, so they're already feeling itchy. So we usually clean the test site, and then we label, so we have a general idea of like what allergen is going where. And then we use that small needle then to basically prick the extracts into the skin surface. And then we'll also put controls on there with it because we need to make sure that our test is valid. So it's a histamine and then a saline. If there's no response to the histamine, then our test isn't valid. And then the saline control is really to tell us, okay, do you have sensitive skin, which we call dermatographism, because that would affect how I would interpret the test. And then once the test is applied, we need to lay very still for about 15 minutes, and then we'll see if the skin has developed red, raised, itchy bumps, also known as the wheals. And that will help us determine sensitization, which means our body has this immunoglobulin E coming back again. That's our allergic antibody to the allergen. The drug allergy and venom allergy skin testing is a little bit more involved, and it does involve some intradermal skin tests. So those do have more of the typical needle with it. We don't typically do those for environmental allergies because it tends to have a high false positive rate, but it is used by allergists in certain circumstances. And then there's a separate type of testing that some people may also sometimes confuse with our typical allergy test. And it's called a patch test. And it looks to see if we're allergic to, let's say, a metal like nickel or a fragrance. And that is basically it sits on the back for about 2 days. It's applied via tape. It's not like come into the office, get it done really quick, and you're good to go home. The patch testing is a little bit more involved, but also very helpful.
I didn't know it was a 2-day long. That's good to know. We always learn about those, and I was like, but I didn't know 2 whole days. That's a long time to have a little piece of nickel taped to your back.
Yeah, and you can't shower in that time.
Oh, and you can't shower. Oh, that's not great either.
My nickel allergy test was they just put nickel on me for jewelry multiple times until they realized that I kept getting allergic reaction to it. And like, oh, you're allergic to nickel.
That makes sense. Yeah. What about food panel testing? That one's become very common. I think like 23andMe or one of those other ones does that, or they advertise this a lot. They're like, I just needed to take a whole food panel testing, and that's how I knew I was going to feel better. Okay, let's break down the fact and fiction. Does everyone need to get a food panel testing done?
No, we don't all need to get a food panel testing done. The problem is a lot of times the food allergy testing panel can lead to a misdiagnosis, and we can have false positives and unnecessary food avoidance. So it's not for everyone. I wish we had a great test out there for the food sensitivities.
Absolutely. I agree. Maybe that's something people researching that can work on. We're putting that out there.
You're right.
So who do you usually recommend undergo food allergy testing?
So it is most helpful for those who have the classic symptoms of a food allergy. So for instance, the 2-year-old who has hives and vomiting after eating yogurt, or a 50-year-old gentleman who had a repetitive cough and red eyes after eating shrimp. Again, as we mentioned before, it's also used in babies with moderate to severe eczema before we introduce peanut. And then it is also recommended in evaluation of patients who suffer from eosinophilic esophagitis, which is an allergic food pipe condition.
Absolutely. And of course, I see that all the time. It's definitely something I refer people for testing, because when I read them the list of things that they have to avoid, and they all look at me like, what? I'm not doing that. So it's nice to find out specifically what they do need to avoid. What kind of testing for food allergies can be completed?
So you can do blood testing, which measures the amount of our specific IgE, that's our allergic antibody, to the food allergen, or the skin testing, as we've discussed before. It's really important to know that neither are conclusive, which means that there can be false positives and false negatives. In general, the skin tests are more sensitive than the blood test. When I'm dealing with a life-threatening food allergy, I typically like to have both. That way I can have as much data as possible, because I will definitely see times where the skin test looks like we're very allergic to it and the blood test doesn't look quite as bad. And then we try the food challenge and it's like, yeah, we should have listened to the skin test there sometimes. And then the only way, as I kind of mentioned already, to definitively know whether someone is allergic to the food is a food challenge. That's considered our, gold standard for diagnosing a food allergy. And it also helps us figure out if we have outgrown a food allergy. So if the food challenge is determined to be appropriate based on the testing results, then an individual would come into the office. We monitor closely. You're there for several hours and you eat increasing amounts of the food allergen.
Interesting. What are your thoughts on these home allergy testing kits?
Unfortunately, I wouldn't recommend them. As I mentioned before, the skin tests are more sensitive, so they are better to rule out an allergy. You also want to be able to visit with a board-certified allergist and immunologist regarding your test results. So with some of these that I've looked into, I can't really figure out who is actually supervising and discussing results. And in one of them, it actually said, follow up with your primary care doctor.
Wonderful.
Oh, yeah. Please don't bring me that whole list and then ask me to do it.
Yeah. No, I get that all the time in clinic.
Please
People
no.
will bring that list and be like, this is what it said. It's kind of like the home cancer ones or whatever.
Mm-hmm.
And they'll be like, what does this mean for these allergies? Like, who you should take that to? Dr. Amanda Lewis. She would love to see that list of allergies that you brought in, and she can test you for what you need to be tested for.
So you're saying don't waste your money on it. Go see an actual allergist so that way you can get the correct diagnosis. We don't end up with some crazy restrictive diet or restrictive behaviors you've sold off your cat and your dog and everybody, your brother because you're allergic to him or something. You just all these things that you think you have this allergy to. Go talk to the actual allergist.
Yeah, unfortunately, there's just a lot of misinformation out there. And so you really want to make sure that, it's basically backed by science and research.
And that is why we are here. That is what we are trying to do with this.
A great summary.
Right. What great information for our listeners. We hope we have answered all of your allergy-related questions. Dr. Lewis, thank you so much for being on the podcast today. Please come back anytime.
Thank you all for having me.
As a reminder, don't forget to check out in the show notes in order to claim your CME credit. There should be a link there. And again, thank you for listening. Please like, subscribe, share the episode. Let us know what other topics you're interested in through Instagram, and stay tuned for our next episode.